there are disparities with regard to survival. Patients who are over 60 with Hodgkin lymphoma have a much lower survival than patients who are under 60. And that has been found partly because of the biology of the disease, maybe a little different, but the major reason is because of reduced toxicity, reduced tolerability to treatment, and more toxicity related to treatment, and also likely also due to more comorbidities. And so our treatment for patients who are over 60 tends to be modified a little bit. One of the things that we really try to be careful with for those patients is exposing them to bleomycin, because they do have a higher chance of having bleomycin lung toxicity. And so one approach could be to try to still expose them to bleomycin, but try to reduce it as much as possible, which is possible if we use the Rathwell approach, where the patients receive 2 cycles of regular ABVD chemotherapy, and if they have a PET negative response, then we drop the bleomycin for the further treatment. For some patients, we really want to try to avoid bleomycin altogether. It's not unreasonable to give them just AVD chemotherapy and just without the bleomycin. It's probably associated with a less favorable outcome, but still could be curable. Brentuximab has been studied in this setting, actually, and there's a very nice data from a study looking at sequential treatment with brentuximab and AVD chemotherapy. And so a regimen where bleomycin was completely taken out and patients received 2 cycles of brentuximab followed by 6 cycles of AVD chemotherapy followed by another 4 cycles of brentuximab. And actually, even though it was very long therapy, the patients tend to tolerate it fairly well. The 2-year event-free survival was about 80% on that study, which is much higher than is expected with that patient population in that age group. And so I think that that is a regimen that I am in favor of using now that that data is out, because I think it's very promising.